presenter, which is Matthew Frei. So Matthew is an addiction medicine specialist who is clinical director of Victoria's Turning Point Eastern Health. He's worked as a physician in alcohol and drug medicine for the last 20 years and has an increasing interest in persisting pain and opioid use problems. In addition to his role in the senior leadership team at Turning Point, he works as a sessional addiction medicine specialist at Caulfield Pain Centre. Matthew's interested in how the intersection of pain and pharmaceutical drug use have, I rewrote this and got it wrong, sorry Matthew. I'm going to read that incorrectly, so I'm pretty sure this is what your presentation is about, so I'm going to skip that because I've messed it all up. Sorry, mate. Just to say, Matthew works closely with our pharmacotherapy network, delivers small group learning meetings, and provides mentor and advice to community GPs. Matthew, I don't want to diminish your excellent presentation, so I'm just going to pass it straight on to you. Thanks, mate.
Thanks. So I'm hoping, is that working?
Yep, that's working.
Fantastic.
We'll make it a slideshow.
Oh yeah. So thanks very much, and yes, I'm going to talk about square pegs and round holes, and I'll try to keep to time, Adrian. You'll be pleased to know. So I'm just going to give a brief history, then talk a bit about treatment, and summarising, we'll hopefully have time for questions at some point. This is just to reiterate that this is this intersection of pain and addiction, and the treatment of pain and addiction has been isn't something that's been a recent phenomenon. It's been known for many years, from before I was born, the year of the Melbourne Olympics, actually. So I just wanted to talk a bit about where we are and how we got here very quickly, and I won't dwell on the history, but I've divided the phenomenon of the opioid crisis and opioids and pain and the issues for drug and alcohol, the drug and alcohol treatment sector, into three phases or three waves. And one was the 90s growth in these drugs, and that's the repackaging by pharmaceutical companies of old opioids to make money out of this very common issue of non-malignant pain. And it was an extraordinarily clever money-making move by Big Pharma, I think, to capture a condition that we were all getting, given that we are living longer, and we're getting fatter, and we don't expect to be in pain. And at this time in the 90s, when I was working in the 90s, when we talked about opioid use problems, we were talking about heroin. The second wave, as I see it, was around the turn of the century, when people started to realise there were some problems with giving everyone with back pain a slow-release oxycodone. And we looked at North America in Australia and saw quite a significant problem in North America, and saw that we were following Canada and the US in our opioid crisis. We saw that pharmaceutical opioid deaths were now the big issue over heroin deaths, and before this we were getting about a death or two a day from heroin, and in the last couple of decades that's changed to about 360 deaths a year in this state from pharmaceutical opioids. And we began looking for what we were going to do about this, and now where we are is we've matured in the opioid crisis, and we realised that this is a problem. We've got guidelines where the recommended maximum dose of opioid equivalency, or OMED, has dropped and dropped. We've got SafeScript, as has been mentioned. Companies have released medications that are difficult to crush and inject, but we still have this problem of people dying from pharmaceutical opioid overdoses in coroner statistics. And looking at North America, we see they've gone into a third wave of resurgence in heroin use. and also the use of adulterated heroin with fentanyl. So that's where we are at the moment, and in some ways being aware or woke to what's going on with opioids would have its benefits, but there's also some unintended consequences, and where we find ourselves now is that in my work I see a lot of people who are now being patients who are being abandoned by their GPs. GPs perhaps rightfully are very worried about prescribing these medications and getting a call from the coroner or from APRA. We see a lot of stigma. The awareness has spread to the community, and I often see people with chronic pain, persisting pain, who are very unhappy about being labelled as drug dependent or addicted. And there's an increasing problem of access to treatment and to pain management, in fact. I never thought I'd be saying that, but that's what's happened. This pendulum seems to have swung to the point where people are getting inappropriately cautious in some cases, I think, about prescribing. There's been a bit of a growth also in alternative drugs to treat pain, and while this may have had some benefits, it's also spawned some agents which probably have their own problems, like pregabalin, the gabapentinoid drugs. So the other challenge for where we are now is our response to opioid use disorder in people with persisting pain and its treatment. So I'll talk a bit about that in a moment. And we've, myself and some colleagues, put together a paper about this and developed the 5 R's. I think there's 6 there, but 7 actually. But I just point out that reversal refers to the prescription or provision of take-home naloxone. Rotation is about changing to a different opioid, but I wanted to talk about replacement. And that's really about buprenorphine. And I'm going at a pace because I know I've got limited time, and I want to cover some key points that are new, perhaps, and are not necessarily information that's easily accessible because it is so new. So I wanted just to talk a bit about the role for buprenorphine, and this was a drug that many people will be familiar with. The brand name of the most commonly used form of buprenorphine naloxone is Suboxone. It was a drug designed for heroin dependence or heroin use disorder, and it has now got a new role, and that's kind of makes sense because what we're managing is qualitatively similar to heroin dependence, but and also we're treating pain with a drug that's essentially an analgesic. So it would seem like a really good fit for buprenorphine, and I'll talk about that a bit more in a moment. I just see something. Somebody's come up and asked me what the last 2 R's were, so I'll do something I never do, and I'll go back. The last 2 R's, replacement, is what I'm talking about now, which is the use of drugs like buprenorphine and methadone for people who are in strife with their pharmaceutical opioids that are prescribed for management of pain. Regulation, it really refers to what's happened in a few jurisdictions, both in Australia and abroad, around monitoring of medications through things like prescription, like things like SafeScript. And in America, they've gone as far as locking people up in jail occasionally. So there's been some tightening of restrictions around those medications. So going back to treatment or replacement, so here's an opportunity for a drug we know has got a great safety profile, to manage this quite huge issue of opioid use disorder in people with persisting pain. And I've written there, what about methadone? I don't have enough time to talk about methadone. Methadone is the gold standard for opioid replacement in heroin use disorder. In my opinion, it's probably got less of a role in the group that I'm seeing with pain issues and difficulties with their medication. So that's great. So buprenorphine is a great drug in this setting, potentially. But the fact is, not a treatment that people necessarily jump into with open arms. There's still a stigma around going to the pharmacy and getting buprenorphine rather than pharmaceutical opioid traditionally used for pain. There's a cost to this drug that's very much higher than the cost of PBS-supported pharmaceutical opioid use for pain. And a lot of doctors don't like prescribing buprenorphine. They often feel much more comfortable prescribing pharmaceutical opioid than they do a drug which has got a very good safety profile, in fact, like buprenorphine. The lack of euphoria is actually a benefit of buprenorphine, but it's something that reduces its acceptance by patients occasionally. And working in pain medicine, I just wanted to write down a few of the responses I get when I am seeing somebody to discuss some issues with their opioid use that's being used for the treatment of their pain, and the sort of things people say. And these are very common responses I get when I start to discuss this stuff. And one of the most important, I think one of the most interesting is this, I'm only speaking to you because I have to be. I'm only here sitting in front of an addiction doctor because I was told that's the only way I'm going to continue to get my medication. So this is a really different paradigm. It's a in my experience, it's a very different way of managing opioid use disorder. People aren't coming in happy to see you or looking for help. Quite often they're there under duress with no other option. They just want to be left alone, often to continue to take the prescribed opioid that their doctor has been giving them. It's only their doctor or their family or the regulators, the Medicines and Poisons Unit of the Health Department, that have told them they've got to look at buprenorphine. So one of the things, we don't get many new drugs or new formulations of drugs in my sector, but one of the things that might be a game changer is, for this group in particular, is long-acting injectable buprenorphine. So some people may be aware of a product that's on the market, a new product. Two companies make this, and they're both approved in Australia, and are both either very, very cheap or free. Very much cheaper than, very much more affordable than sublingual buprenorphine, the traditional form of buprenorphine. The brands are Sublocade and Buvidal, and these depot injections that people are given once a month of buprenorphine, so they get effect of this drug over a month. They only have to visit for administration once a month, and as I mentioned, it's got a great cost advantage. The other nice thing about injectable buprenorphine, I think, in pain patients, people with persisting pain, is it kind of takes the focus away from medication. And I'm talking about medication. I know the topic of this webinar is about a lot about the biopsychosocial approach. And what I probably should have said initially is, and what people have raised is that, and what I've learned about pain in working in a pain clinic or pain clinics, is that when medication is is not ever going to be the answer to the management of persisting pain, of non-malignant pain. You know, one of the biggest, I think, disasters to happen is the promotion and growth of iatrogenic dependence on pharmaceutical opioids prescribed for persisting non-malignant pain. I think that's been a huge medical embarrassment and tragedy, because it's becoming clearer and clearer that medication has got a tiny part of, a tiny role in the management of persisting pain. Unfortunately, it's been the focus in the minds of a lot of treating doctors and patients. So I'm going to finish by summing up about where we are and summing up what I've just said. So, as I mentioned, this is the Matthew Frei phase of the opioid crisis, and we're in the third phase, the third wave, where there's a lot of awareness. I mean, some GPs have got letters in the mail from the government saying, you know, we're watching you, because of their prescribing. So there's not anywhere near the lack of caution there was perhaps a decade or two ago around prescribing these medications. We've got safe script, but we've also got some growth in stigma and access problems, and we haven't really had any change in fact we've probably seen increasing numbers of people, at least before COVID anyway, in the coroner's statistics dying of multi-drug toxicity where a pharmaceutical opioid prescribed for pain was involved. And as I mentioned, where problems with pharmaceutical opioids become difficult to manage, there seems to be a role as a safe and or a lower risk option for buprenorphine, and its advantage is its very good risk profile and its ability to manage symptoms of opioid dependence without causing a focus on the medication or without the level of reinforcement that drugs like oxycodone or fentanyl have. And adding to that is the fact that we've got products that can be given as a depot injection that are either minimal cost or free to the patient. The theme I wanted to go into in this presentation was about the, and which I hope I've conveyed, is about the similarities and differences in approach and treatment of pharmaceutical opioid use as compared to heroin use. It has caused a rethink, a change in the treatment sector, in the alcohol and drug treatment sector, in that this group, or people with persisting pain who get into difficulty with the prescribed opioids, they have a lot of similarities, and there's also a lot of differences in the framework or in the picture of this group. And probably the biggest difference for a clinician is the approach to treatment, which is very different. It's a much harder sell to somebody who is has an understanding that their treatment is it's not illegal. It's not in most cases it's not injected. It's not going to put them at risk of a local or systemic infection. It's relatively affordable. So as a group, they often are less accepting of buprenorphine treatment. And there seem to be two groups actually. There's some people that do incredibly well and thank you profusely for changing their life when they're commenced on buprenorphine, and there's other groups that are really incredibly resistant, and you know, that's medicine, and the art of medicine is working with people and the differences between people. So I hope I've kept to time. There's some numbers there, and some options for referral or support. And yeah, I'm happy to take questions or to partake in the panel to answer questions, and I'll hand it back to you, Adrian.
Fantastic. Thank you so much, Matthew. Yeah, we are, it's entirely on me without like telling people, giving people the heads up about time. We are still running a little bit behind, so we'll leave questions to the panel, but please, anyone in the audience, if you've got any questions for Matthew or anybody, stick it in the Q&A box and we'll answer it in the last part of the evening. So I just want to quickly give a very quick plug about the work that my organisation does. As I mentioned, I work for the Area 4 Pharmacotherapy Network, a Department of Health funded initiative set up by, led rather by Southeast Melbourne and Eastern Melbourne Primary Health Networks. So our main role is to improve client access to opioid pharmacotherapy services, methadone and buprenorphine, as discussed by Matthew, in Southern and Eastern Metropolitan Melbourne. We do this primarily by encouraging and supporting GPs and pharmacists to engage in delivery of those services. So our overall aim is kind of like what Matthew was saying, to try to like make this treatment a normal part of general practice and community pharmacy, to destigmatize it. We want anyone to be able to access it without fear of stigmatization. So events like tonight are a key part of our work, but we also offer an advice service, which you can access with our GP mentor, Anne-Marie Diggins, who will be on the panel at the end of the night. Oh, there she is. There's Anne-Marie. Hi, Anne-Marie. Or one of our addiction medicine specialists, Matthew, who you just saw present, is for Eastern region, and David Jacker is for the Southern Eastern region. For general practitioners, we offer in-clinic education, which is available in an online form. We also hold regular small group learning meetings for GPs and pharmacists interested in pharmacotherapy. And pharmacies, we offer assistance in setting up a pharmacotherapy program, ongoing mentoring and ORT advice. We also engage with the AOD sector regularly and can provide staff education and pharmacotherapy advice to AOD organisations. So that's what we do. That's kind of one of the reasons why we hold these events. So hopefully you guys are all here know a little bit more about it. We'll provide some of our details